Q, you can share your screen.
Prof. Herat is going to go first because he's on call. So we just
Okay,
thought you'd go
that's
first.
perfect. Okay, no problem. Okay, no problem.
Thank you.
Kirat, we'll just give another minute or two.
No problem, Prof. Thank you.
Good. Kirat, are you able to share the screen?
Yes, Prof. It should come up just about now.
Very good. Okay.
Okay. Can everyone see the presentation?
Sorry. Yes, I can see it, Kirat.
Okay. Are we still waiting for anyone, Prof?
Let's just see if there is anybody waiting. I see Yashoda is here. Rest all of us are here. It's only Selo and Kululeko not here yet. We are just at 5 o'clock. Kirat, I think we can start because you're on call as well. So let's start. Okay, so yeah, okay, Kirat, okay.
Please excuse me for looking one direction and talking another direction. It's just so that I can share the computer screen here at the hospital. So today I'm talking about the ethics of operating on family. And then I just want to pose this question to everyone. Would you operate on a close family member, a partner, a child, a parent, or even a grandparent? So during my reading, I found lots of articles, surveys, studies, opinions, actual cases that were reported on. And it seems to be a consistent dilemma faced by many surgeons under multiple different circumstances. One should always consider the factors that are at play here. There's a big difference between excising a tiny mole versus major surgery on a family member. So I did find a code of medical ethics. It's the American Medical Association. Their opinion 8.19 states that the physician generally should not treat themselves or members of their intimate families. The American College of Physicians ethic manual states that a physician should avoid treating themselves, close friends, or members of their own family. In my reading, I found that some hospitals in America even forbid the operating on family members. From the medical principles and practice, there's a survey that I found. It's when you operate on friends and relatives, results of a survey amongst surgeons. This was done looking at professional board of German surgeons. About 17,000 surgeons were asked to partake, and about 1,600 of these surgeons completed the questionnaires. Of these, 77.6% had previously performed surgery on friends or relatives. 50% said they would perform the operation if the friend or relative asked them to, and 17.2% said they would do it only if no other surgeon was available. Some of the other answers that were prevalent that were included was that because I have mastered the procedure the best was the answer of 30.6%. Because I want to have full control over the procedure was what 20% said. And because I have good experience in the situation was 23%. The study also further breaks down how the percentage of surgeons that operated on family members, how many of them were some of the senior surgeons and their institution, etc. And it seemed that most of them were quite qualified. Of the 20% roughly that said they would not operate on a friend or a relative, some of them gave the following reasons. 62% said, I do not feel good about it. 50% said that this was a multiple answer question. The patient-doctor relationship does not work that way, or objectivity is missing. So just in summary, most surgeons who responded accepted the task of operating on friends and relatives. they did mention that performing surgery on friends and relatives was a complex matter, and that one of the difficulties was that objectivity couldn't be guaranteed. Negative implications on personal relationships were rare, however, and this study in the end recommended that this should all be considered and that ethical guidance or code should be created for surgeons. So this is just an interesting little case that they used in the article that I will go into a little bit further. They say, you have developed an effective new surgical procedure to treat a previously terminal disease. The statistical data indicate that you have mastered the learning curve and can perform the operation with low morbidity and consistently good outcomes. Colleagues are beginning to visit your institution to observe your conduct of the procedure, and you plan to present your results at a small series of patients at an upcoming national meeting. You have many years been recognized as one of the most technically skilled surgeons working in your specialty. This week you learned that your grandfather has just been diagnosed as suffering from an advanced stage of the condition for which you have developed a new operation. So, the question I'm about to pose is, if you would operate on your grandfather. Reagent et al. Found that physicians were most comfortable operating, or not operating, but providing treatment to their own children, and were least comfortable providing treatment to a grandparent, thus the use of a grandfather in this case. Something to consider is the role of emotions. So in the reading, they were saying emotions almost act as a filter on your experiences. They can either augment or moderate your response. You might be very invested in a family member. This might alter your course of treatment. You might do things you will not otherwise do. You might keep doing things that you know might be futile, or in another patient you wouldn't. They use a very interesting example of a tiger, as they say, if you were in the primitive times back in the day, if you heard a tiger was near your tribe, you would be very concerned. Whereas if you heard a tiger was on the other side of the river near an enemy tribe, you would be very relieved. An interesting quote I found was, as Sir William Osler recommended a century ago, surgeons require to detach and impermeability because the performance of major surgery is counterintuitive. In any other situation, the slicing of another person with sharp instruments and invasion of the internal organs is the gravest manifestation of aggression and ill will. Surgery harms before it heals, and the consequences of misadventure can be terrible. A clear, disciplined, and decisive mind is critical in evaluating when and how to operate, manage contingencies, and control risks. So, in the article, they posed these 5, let's say, simple options of what treatment you could offer to your grandfather. I'll go through each one of these pros and cons a little bit. I don't know if anyone has a certain preference here, but yeah, let's just move to the next one. So option A, legal and professional prohibitions prevent you from operating on a family member. So as far as I did reading, I couldn't find any laws that said that you cannot operate on a family member, but the same things we normally have to abide by, informed consent, still play a role. They mention here how important giving consent is, let's say for a close family member, that you don't skip over any terms, you don't skip over any possible bad outcomes. You do the most and you explain all the terminology, you do it just as you would for a normal patient. Uncomfortable truth, they say you must also consider, is that you must also talk about end-of-life care and possible complications and what this could entail. You must accept the established ethical principle that a surgeon cannot operate on a family member under any circumstance. So this is another option that I think personal role and opinion and at the time play a big role. Let's say, for example, you are, oh, sorry, Prof. Let's say for a moment, you are the only surgeon available at the hospital. For some reason, you are locked in with a family member who sustains an injury. Here you are with the theater, all the equipment, even let's say for basic hemostasis. Now, will you allow this family member to bleed out for the simple reason they are a family member and you do not operate on a family member? I'm pretty sure that no one would do that, but yes, this is just a point I thought I would mention. So then the other option is you have a qualified colleague at another institution to do the procedure. In this case, we have to dismiss this option because you are the one that is on the forefront of this procedure. There's no one else doing this procedure. But even as you could see in the multiple answers section, you can see in the beginning is that you have seen in the beginning is that 30% of surgeons prefer to do the surgery mainly because they wanted to be in control of the circumstances. I think this goes with they being at their institution, the institution they know the processes, it's familiar to them. And then the other thing is that, yeah, it was one of the main reasons they were willing to operate on family members. Then have a colleague do the procedure under your direct supervision. So this is definitely how skills are taught in our setup. We get allowed to operate with a senior prof, whoever next to the bed. But let's say we are into deep and there is trouble, they are always there and they are able to come and assist us. So if this is your family member, you must remember that you are in a position that if the one that you are supervising, even if it is a trusted colleague, if they need help, you will have to step in and take over and manage the risks. This cannot be ruled out. So our last option is option E. If your grandfather agrees, you should do the procedure. Now this seems like a simple and easy answer and fairly easy to accept. If your grandfather consents, he has no objections, easy, you can do the operation. But one must remember the hierarchy in families. It is possible that your grandfather is a very well-respected member of the family. Now, you might even be the grandson that is the youngest now, or granddaughter. Now you are the one that needs to find out perhaps uncomfortable history from him. Will he easily disclose all of this history to you? That is another question. Will it make him uncomfortable? Then after this, you must make sure you, as I said, informed consent. Make sure you explain everything to him. Don't soften the blow. Be honest and open with what the procedure has to do. And then another thing you should think about is the rest of the family. You have an obligation to your patient for confidentiality. However, your aunts and uncles might call and say, hey, how's grandpa doing? How is this? How is that? You have to make sure that you've clearly stipulated with him and agreed that this is what we will disclose to the family. This is what you are comfortable with, as with every other patient. The other problem is they talk here about having a hero complex, wanting to save your grandfather. Even if you know this is maybe not the best procedure, you're willing to risk it, even though the chances are bad, the morbidities are high, just to get that recognition from the family. However, the opposite is also true, that are you prepared for if, let's say, the procedure complicates? It's low, but not completely no mortality or morbidity. Will you be able to face the wrath of the family? Will you and grandmother's relationship remain intact? These are all questions you should ask yourself. I try to make a little conclusion, but yeah, it's not as simple question as one would think. There are multiple different factors that are playing a role. As you can see from all of the different discussions that there are about this topic, it's a very difficult and no clear-cut answer. It depends on your personal feeling, relationship, opinions. Will your grandfather take your instructions on post-operative care, or will he say, this whippersnapper doesn't know what he's talking about? is it worth the what if to you? What if it complicates? What if something happens? And then make sure you are still looking at him objectively. Don't do him or yourself any injustices. Consent, good clinical practice is important. And then a nice tip that they gave in the article for doing this is they said, instead of referring to Grandpa Paul or Uncle Sam or whoever, talk about the patient. Get a trusted colleague, discuss the patient with the colleague. Ask them if they think your clinical judgment at this time is sound, if they agree with your opinion. And if they do, then this is a good sign that you're on the right path. But never lose track of treating the patient the right way. Yes, so here are the articles that I referenced. The questionnaire was done in 2017, but I found multiple articles back from 2015. It's a consistent question that has been around. Thank you, Prof. Are there any questions?
Gerard, that was very good. It was a nice summary, and we decided to present it because it's an ethical dilemma, and there is no right or wrong answer. So I think you have presented it well, and you have summarized it well. I'm just going to ask our colleagues to comment, and I'll just unmute those who would like to make a comment. So let me just get a full screen view. Sorry. Please let us know if anybody would like to make a comment. I'll just, if you just put it in the chat box that you want to make a comment, then I'll just unmute that mic. I see Dr. Lazarus has joined a bit late, but Colin, this talk was about whether one should operate on close relatives or close friends or not. And Gerard has presented it. I don't know whether you want to give your thoughts about it, your opinion.
Thanks, Melinda. I did join too late.
Yeah.
What I heard was very interesting. And Gerard, thank you for presenting that. I have nothing more to add at the moment.
Okay. Please, Selo, Yashoda, I don't see Dr. Majola, but or anybody else, I can quickly unmute. You just type in the chat box that you would like to make a comment or ask a question.
Hi, Prof.
Yes, Yashoda. Yes, please go ahead.
Yeah, so I think that was really good. I think Gerard went through all the ethical issues that are pertinent and extreme cases where it might become more of a dilemma. But in general, I think, I mean, all of us have been in the position when we had to advise or treat family and friends. We, all doctors or even medical students, get into that position. So I think we have dealt with that, and then surgery is a step further. So I think anyone would avoid it as far as possible, but there are extreme cases where it might be the best option.
Yeah, good. Thank you, Yashoda. Yes, I see a comment from Helga, and yeah, there are no legal restrictions. The HPCSA also does not give us guidelines that we should not operate on close family members or relatives. It's a personal choice, and then there are implications which you have clearly mentioned. I'm trying to just unmute Selo and to get his comment. Selo, can you unmute yourself? Yeah, okay.
Yes.
Selo, any comment?
Yeah. No real comment, but I'm just saying that regarding treating any family member, I think it just has to do with the condition it is, because it's a bit easier if it's a non-terminal case or patient that you're dealing with versus a surgical or even a terminal care where you have to deal with end of life issues, because simple examples, a child or a friend or a girlfriend or whatever has tonsillitis, you can easily just write antibiotics and continue with your life. But should the same person have breast cancer or colonic cancer or whatever, you would try not to deal with that. You try to actually get someone who's more knowledgeable in that field. Fair enough, it comes to a state where you might end up being the most knowledgeable one at that time, and then it's very difficult to actually be non-biased, because you always have bias towards family members or close friends. And even with certain patients, we've seen that you always have bias when you've had a long drawn out relationship with certain patients, where you go above ends meet to actually try to sort it out. Not that you don't do the same with other patients, but the second you have that relationship, it distorts certain things, and you don't actually have good objectivity because of the bias. So I think it just depends ultimately on the condition of the patient you're treating, and what it is you're treating. And because the simple things are easy to sort out, the more challenging ones, that's when ethics come into play. Yeah, I think that's my 5 cents for the day. Thanks, Prof.
Thank you, Selo. Yeah, I think our dilemma was about a major operation, and you have covered that. So if there's anybody else who would like to make a comment, we will take comments. Otherwise, we will conclude Kherad's talk. Anybody else? You can just either unmute your own mic or just type it in the chat box. Otherwise, we'll proceed to the next talk. Can we proceed to the next talk? Okay, Kherad, I think.
Thank you, Prof.
No more comments. Thank you very much. I'm glad that despite of being on call, you could manage your presentation. It was very well done. Okay, Panita, I might need to unmute you. Yeah, you are unmuted. So you
Yes.
can share your screen, and Panita is going to talk to us about ethics of use of WhatsApp for medical communication. And there was a nice article in South African Medical Journal a couple of months ago. So she's basically going to review that article and then sort of talk around it. Okay, Quarita, go ahead. We might have to change the meeting to the second meeting, but I'm just going to see there are still about 20 minutes in this meeting. So we can continue with this meeting for now.
Okay, Prof. Kirsty just needs to share her screen,
Okay.
please.
Okay. Yeah. The screen share is there for multiple participants. So Kirsty should be able to share her screen.
Sure. Okay, good evening, everybody. So as Prof mentioned, I reviewed an article basically that spoke about the use of WhatsApp groups in the clinical setting in South Africa today. So why do we use social media in the clinical setting? Well, it is a means of instant communication. It is a platform that we can share opinions and thoughts with the multidisciplinary team treating the patient. It's also quick and easy means of communication. It's cost effective as well, and you have the ability then to communicate and share with practitioners even in rural settings. There's also improved specialist accessibility for complex cases, and WhatsApp is also currently being tested as a learning tool as well. So why not to use WhatsApp? Well, obviously it's a form of social media, and once a message is published or any information is published and it's out there, it's very difficult to get it back. So a message is considered published once it's been seen by the recipient. And as per journalist publications in newspapers, it's also then subject to certain rules and scrutiny. So just regarding the ethics of it all, glaringly, there's a lack of confidentiality in the way we use WhatsApp in the clinical setting in South Africa currently. Often there's also a lack of privacy, and more often than not, we don't get consent from patients for specific information that we communicate between colleagues. There's also then a risk of storing patient information on personal devices and servers that we don't always bear that in mind. And often, after receiving a day's worth of information on WhatsApp, you open it up on the weekend and you realize that all the pictures and all the information has been stored on your phone without you even realizing. The use of social media, however, there are specific HPC, say, guidelines that help us with the ethics regarding the use of social media. And we'll visit that a little bit later. So in terms of the legalities, there is no definitive legislature actually as to how we use social media in the clinical setting within South Africa as it stands. So we basically use the law and the constitution of the country to form the foundation of how we use social media in the clinical setting. One of the major issues that came out in the article is the issue of defamation, which in the country as a whole, according to the constitution and also according to the use of social media in a medical setting, online defamation is never tolerated. And there is the Crimes and Cybersecurity Bill that states that it's unlawful to distribute or broadcast a message that is harmful to another person. So even though it's not specific to WhatsApp and using WhatsApp in the clinical situation, we can use this law as a paintbrush to kind of encompass the use of WhatsApp as well. So that basically dictates to us that any form of defamation will not be allowed or tolerated. And this goes when communicating about patients on social media as well. So in practice, on the next slide, please. The use of social media is ethically acceptable as long as it doesn't infringe on the rights of others. Excuse me. Bearing in mind that if the message is seen, as mentioned previously, it is considered published. Groups are further complicated in that all the members in the group become part of the chain of publication. And the group members then are as responsible as the original publisher for all the messages that get distributed amongst the group members. And if offensive content is viewed and one does not distance oneself from it, it is then considered that one has accepted the content as acceptable. And this is very dangerous in our situation. And I don't think we're actually as careful as we ought to be regarding this. So the group administrator, unfortunately, carries a heavier burden than the rest of the group members. This is usually the person who starts the group. There may be co-administrators as well. They may be appointed by the administrator. And once you start a group, you remain the administrator until you leave the group. After which point, WhatsApp then appoints someone else as the administrator. And you may not be aware of the fact because they don't send out any notifications. So you may not be aware of the fact that once the original administrator has left the group, you may now very well be the administrator responsible for all the communications within that group. So As I just mentioned, you may be considered responsible for all the posts, even posts by other group members. And one would need to act quickly and decisively to comment on any negative posts. One then needs to delete the post immediately and also remove the offending member in the group. It's important just to bear in mind that as the group administrator, if there's any legal court case or something of the sort, you may be subpoenaed for the full transcript of the discussions if the case goes to court, which can then be used as evidence. So just a few implications in the healthcare setting. Content in WhatsApp group chats is actually classified as medical records. And as with all medical records, it is regarded as confidential or should be regarded as confidential information. Sharing of information is considered ethical if it's with the treating medical team for that specific patient. And it's also considered ethical when sharing information is within the interest of the public. The patient needs to consent to sharing the information in writing, especially if it's larger groups. So if it's WhatsApp training groups, if it's communication with a consultant or specialist outside of the usual group of treating doctors, patient actually needs to give written consent for the information to be sent via WhatsApp. And with regards to minors who are little ones under the age of 12 years, in that case, the guardian then needs to give written consent for the communication of this personal information. HPCSA advises that when in doubt about consent, to err on the side of caution and refrain from sharing the information. So with regards to protection for the patient, confidentiality is always of utmost importance. And if there is a breach in confidentiality, the patient then has a few options. So they can institute civil action. They can also lay a complaint with HPCSA against the medical practitioner, or they can lay a complaint against the employer to take disciplinary action against the medical practitioner that breach confidentiality. However, with regards to protecting the healthcare practitioner, HPCSA doesn't actually state what one should do if one is implicated in disclosure of confidential information. The defense provided by the HPCSA is unclear, so we don't actually know where we stand with this. And to date, there's no official documentation offering us as healthcare providers any protection at all when there is a breach in confidentiality via social media. So that's an important thing just to bear in mind, because we use it so freely, and yeah, we actually have no defense when we use WhatsApp to share medical information. Okay, so just some going into some guidelines for after all of that scary information, some guidelines for group administrators using WhatsApp. Again, the article repeatedly reiterated that your post is considered published once it's been seen by more than 2 people. If someone shares something inappropriate, you must immediately distance yourself from the post. You are allowed to identify a co-administrator and then almost share the burden of responsibility with your co-administrator. And it's important to inform new members of the group, which I thought was particularly important when we're getting a new intern every second week that rotates through the group. We actually need to share with the new members of the group, the aim of the group, and also the rules surrounding communication within the group. We also need to ensure that all members are aware of the group rules and agree to these group rules. The administrator, in essence, actually needs to keep record of this agreement with each group member. There also needs to be an established clear route for complaints regarding inappropriate group content, and the administrator needs to respond to complaints immediately. There was also mention of the fact that ideally the administrator should attempt to know all group members personally before adding them to the group. However, in our setting especially, this may be a little bit more difficult to do. So with regards to that was guidelines for the administrator, and now with regards to guidelines for healthcare practitioners, it needs to be made clear that the aim of the group is for objective medical discussion. It is presumed that consent for patient information shared has been given in writing. The content of the group should not be shared outside of the group. This includes posts and screenshots from the group that should not be shared on other platforms of social media. Confidentiality of your identity, however, cannot be guaranteed once you've published content. So again, here, it's so important that you are aware that what you post can be used in future if a case like this goes to court and your confidentiality in that case may not be kept.
Thank you. Can we just move on to the
Yes.
next meeting, please? Just less than 1 minute. So I will end this meeting and we'll start the second meeting.
Okay, Prof.
Okay, yeah. So I'm just ending and then we'll start the next meeting in a second. Okay, Q, you can continue. Huh?
This is actually the last slide.
Okay, good. So no problem. We'll have time for
So
discussion.
this is just this is just the continuation of the guidelines for healthcare practitioners. Another interesting point that I came across is that healthcare practitioners have the freedom to leave any group without having to give a reason. Oops. And then, as mentioned, if there's any defamatory or inappropriate content that should be deleted, any irrelevant content may also be deleted, but this is at the discretion of the administrator. Again, grievances regarding group content needs to be discussed with administrators privately. And another thing that and I speak for myself as well when I say this, that we need to do is ensure that the pictures that come through our WhatsApp group aren't automatically stored on our private devices. And the last point is just that the administrator's decision is final. So if the administrator of the group believes that there's irrelevant or inappropriate content, the administrator has the right to then delete what they deem unfit for the group. And their decision is final, and you can't actually fuss and moan about that because they are officially in charge of the group. So that is basically the end of my chat. There were quite a few things that came up that stood out for me. As I mentioned, pictures, clinical pictures of patients stored on my phone without me even realizing. Yeah, and I'm sure others in the group have also, thought about similar things while I've been going through. So we can maybe just discuss how we as a team would improve our communication via WhatsApp, because I think we're falling short in certain areas, and I think we can improve in those areas.
No, Q, that is the entire purpose of your talk, and you have clearly pointed out. I think all of us have thousands of photographs which we receive by WhatsApp of our group, then maybe oncology group, the wound management group, and we need to make sure to delete all these photographs as soon as we have dealt with the clinical situation. Q, I would request you, once we get advice and input from all the members, to sort of set up a policy or how to make changes, whether we need to have something in writing, and keep a record of that. But I think before that, I'm just going to ask others to contribute. I think let's start with Selo. Selo? Yeah, Selo is still here. Let's unmute Selo. Selo, sorry, can you unmute yourself? Yashoda, I have, sorry, I'm just finding it difficult to unmute. Okay, Yashoda.
Unmute. Okay.
Yeah,
Don't
okay.
touch anything.
Okay. Okay, sorry. Okay, go ahead, please, Yashoda.
Okay, so yes, another important topic. I think we have been treading very dangerously on these boundaries of privacy and confidentiality. It's difficult because it's going to be a challenge if we wanted to move away from WhatsApp, because it's ubiquitous. Everyone has it, even in the peripheries, everyone has it. Everyone knows how to use it. It's a very easy platform to use for communication in general. So it will be hard to try and change that. But we should be looking for more appropriate platforms. And that's why the Vula app is promising for our referrals in particular from the periphery. So those things, we should be moving towards Vula rather than using WhatsApp with referring doctors, because it has all of those issues, built in, the privacy and the pictures and those kind of things. Doesn't save on your phone. So the other thing I wanted to say was we must be ethical in how we communicate with each other as well. Obviously, it's in a professional way. And even if we do share details about patients and things, you need to do it for the patients, for patient care. It shouldn't be just discussing patients, for patient care, and that has to remain okay. the other thing I wanted to say is that we shouldn't be discussing patients on our pediatric surgery team WhatsApp group. We should be using it for handovers and just for distribution of work and those sort of things. We shouldn't be actually discussing patients on there. And I think we should be doing that in face-to-face handovers. And I know it's become a bit difficult now in the age of COVID to have those face-to-face meetings, but I think it's very important that we do that in person. That's where you discuss patients, and that ensures, confidentiality, privacy, and that it doesn't, so that kind of information doesn't leave the people that should be involved. So we should, as far as possible, have those meetings, even our M&Ms, even on these Zoom meetings when we discuss M&M, that is a more appropriate platform. So when it comes to just communicating with each other for work distribution, telling people where they should go and what they should do for the day, that's fine. But discussing patients, I don't think should be done in there. Our burns group, I think that's probably our biggest challenge, because we did it so that everyone could see what the burns looked like, because there are different doctors who are doing the debridements, doing the dressings at different times. So I am open to any, alternative to a WhatsApp group, because I think that's probably the group that has the most problems with regards to this legalities and things. And I think as far as possible, we should avoid using pictures with faces, at least.
Yeah. Okay, Yashoda, thank you for pointing out your concerns. I think it's going to be very difficult not to use WhatsApp. I think we must just find out a way of doing it in a legal and a safe manner. And for that, we may need to agree to certain rules, and like you just mentioned, not to include the face of the child. And I don't know whether it is necessary not to include the name, but probably it's difficult to identify a patient unless we write initials of the patient or something like that. So I think we probably just need to be more aware and more careful. Selo, sir, I'm trying to unmute you. Are you able to unmute yourself? I can't seem to be able to do that. Okay, Selo.
Yeah. No, I was not hearing anything, so I had to go out and go in again. But yeah, that's why I just couldn't hear anything. But I just think that we just have to find ways, as been said, of trying to keep up, because ultimately we are modernizing. We cannot still we see now with the COVID thing that we are able to have meetings via Zoom and everything like that. So we just have to find ways of keeping any information you're distributing via WhatsApp or any media platform confidential. Ultimately, as is stated, stating the patient's full name or having pictures of the patient is of the patient's face specifically is not of any benefit, unless if the pathology is on the face. If we're looking at a testicle, penis, looking at the abdomen, that's just focused on the abdomen, and we can use anonymity and not actually state anything related to the patient. Just say the 10-year-old boy, 10-year-old girl, and just deal with that. The same way we're dealing when we're presenting M&Ms, where we still just saying patient MN presented with this problem. We all know who patient MN is, but if someone outside the department was to look at the folder and say, or look at our M&M meetings and say, they will have no idea who patient MN is, who came in with gastroschisis or whatever it is. So if any patient, if we're forced to discuss any patient on WhatsApp, I think mentioning that the age and what the patient has should suffice. Telling us what the patient's name is, that he's the last born of 5 kids, and all those extra things might not necessarily be beneficial in the group. In a one-to-one basis or face-to-face in a discussion, fair enough, yes. But on WhatsApp or any media platform, we're just trying to get the crux of the matter. So I think, like, keep the information pertinent. Like, or as they're saying, you must always just talk about the important negatives. So telling us about that there's no running water at the patient's home and everything is good, but to knowing that the patient has appendicitis, it will not benefit us in any way at that point in time. So just be more, long story short, I think the important thing is just to focus on the pathology. I know we're not dehumanizing the patient, but focus on the pathology of the patient on social media platforms. And when we are actually interacting personally, then that's when we can talk about the patient's name and social demographics, etc. Thanks, Prof.
Yeah, no, Selo, I fully agree with you. Very nice practical comments, both from Yashoda and from you. Dr. Lazarus, Colin, do you have any, you will remember a few years ago, one of our MOs, she presented a poster because you had asked us to look at the legalities. So any thoughts, Colin?
I must admit that my thoughts are less pertinent in this setting because, as you know, I don't correspond that much in this particular forum. But the comments that have been made are really pertinent, and I found them very, very helpful. The thing was that they overlapped with my contacts in the Granddad's Army. And then I heard about responsibilities of the administrator. And that sent a little bit of a shudder down my spine. So, you know, I think one just really does, particularly when you get large groups, one has got to find a mechanism by which one does send the basic rules around on a regular basis, you know?
Yes, yeah. Yes.
Thank you. That's probably all that I had to say.
Yes.
It's been very interesting discussion, both of these presentations. Thank you.
Yes, yes. Helga, I see you have a comment, so you can make a comment about what you have put in the chat section, or in general, especially about our wound management burns group.
Yeah, Prof, there is an alternative to WhatsApp. It's a South African-based app called Synapse, who have been trialed by a few departments in the country and has recently gone bigger and better, where you post information to a certain patient under a patient's profile with all the detail. It's also good for collecting information about a patient, but it keeps it similar to Vula, not on the phone. They have complied with all the confidentiality rules in South Africa and also Europe to make sure that patient confidentiality is maintained. But as Vula, they also require that we say to our patients that we are sharing information with other doctors. The issue with Synapse would be similar to WhatsApp in B4, where there's bad reception, but it should be able to work. And in terms of wound care for burns patients, it might be very difficult to not put a name with the wound pictures, just to be able to identify the patient and know who is who and who we're talking about, especially if we have multiple people looking at different wounds and having to make decisions. It's just to try and avoid confusion and mistakes from that part of management if we don't identify our patients properly.
Okay. Mia, you are one of the co-administrators. Any thoughts about this?
No, I mean, I think most of it has been said by Yashoda and everybody else.
Yes.
But I also want to for referrals from the periphery from other doctors, I think we need to go to Vula and then WhatsApp for that. And then what, like Yashoda said, on the WhatsApp group, also like just not specifically patient information, but just also like, yeah, just handovers, basic handovers without names, and like just that to say like who does what, whatever sort of like, but not patient information as such, and definitely not with names, initials possibly, or just describe the patient without a name.
Yes.
And then I was going to say, because I know about Helga, what Helga said, also like Synapse. The only problem with Synapse is sort of like, I think you need to pay for it. But that seems like, and in that platform, obviously you can put your name with the patient because it is patient-based, like all the pictures are under a certain patient. And it is a secure platform for that, for the burns possibly then.
I would like to comment on Mia.
Yeah.
We share a lot of patient stickers with all the information. Like the last two messages on our pediatric surgery team WhatsApp group is 2 patients, please can Freya team book them for circumcisions. Those things will then not be able to be done on WhatsApp. If we say we can't share patient.
Yeah, that was me.
Yeah.
And yes, I do. Yeah, I do agree. It doesn't, I mean, we do this all the time, but we need to come up with a better system.
Sorry.
And if that's
I didn't
Synapse, then
why should we not discuss that? Is it because patients
patients,
It mentions the name and the pathology, sort of.
I see.
Well, not just that, it gives the hospital numbers, where they stay, their date of birth, possibly their ID numbers, the entire details are on that.
I see. So
yeah.
if it is leaked or hacked, then that's a problem. Is that what you are saying?
Also, if you save, so you can put it in WhatsApp that all pictures sent don't automatically save on the phone.
Right.
Which means it remains within WhatsApp. So that would be one way around of preventing this from coming onto the phone and then being sent to other people. But it's technically published information. And if we don't consent our patients for that, that can be legally a problem. But it's also between the onco and the ped surgery group where we share patient data frequently, where they ask us, can we please put a port? We say, yes, sure, and put it onto our group. That is sharing information between 2 groups now. That makes life even more complicated.
Yeah, I see Kirsty has written a comment that we should add a section into consent form. I'm not sure whether we can really take a legal consent from a patient to share their information on WhatsApp. I don't know the answer. Juanita, Yashoda, Selo, they can make a comment about it.
I think our consent forms are quite open already. We kind of just take general consent to use their information with, but we do say with confidentiality and with anonymity.
Correct.
We are guaranteeing them that on the form that we currently have. Am I right?
Yes,
anyone can?
No, you're right.
Prof?
Yes, Juanita?
Prof, I think it's less of an issue if this information is used, you know, between the treating doctors, the people who are directly treating the patient. I think then it's less of an issue because we are directly involved in patient management.
Correct.
For that specific patient.
Correct.
I think it becomes more of a problem when there are, I was thinking, like Helga mentioned, interdepartmental groups is the one thing. And the other issue that came up was possibly the sharing this information in a group with interns that are rotating through the department. I thought that was possibly a bigger issue than us sharing the patient information, because we are the treating doctors for the patients in pediatric surgery. We are their primary doctors. However,
Yeah.
if it's interdepartmental and with interns that are only with us for 2 weeks, that may blur things a little bit further. And I think that's where it starts becoming more sticky. Yeah.
I get your point. I get your point. I would like opinion advice from Mia.
I don't know what to do about that. But in
Can
terms,
we,
yeah.
can we not
Well,
include on the group?
I do have one suggestion,
Yes, please.
Mm.
because the article that I referenced did the list of basically rules for WhatsApp communication to be ethical. So
Mm.
we would need to then frequently post those rules for administrators and group members, so that every time there is a new person coming onto the group, we then need to publish this within the group so that everyone's aware of this every time.
Okay.
Yes, I would agree with Q that that needs to be done. But I also want to make a practical point here, is that yes, we need to be careful about confidentiality and sharing stuff on. But when it comes to administrative things, no patient is going to sue you because you put their, whatever up on the group. They don't even know. So these legalities come into play when there is actually a problem. Or at least that's the way I see it. It's a practical thing. So as long as we are ethical about what we are doing, and yes, make these provisions for confidentiality and privacy, then I think, we shouldn't overthink it.
I do think, though, that we live in tricky times. People see us taking pictures with our phones. I'm sure they're wondering, where do those pictures go? So for me, I think people are very much aware, and we live in tricky times in that we need to safeguard ourselves, because we don't have any form of defense if these things must be leaked at all.
See, two things. Whenever I take a photo of any patient for any purpose, I ask verbal consent from the parent. Can I take a photo? And I tell them what is the purpose of the photo, whether it is to discuss with a colleague or to see the follow-up result, etc. So I think that is a verbal agreement between the parent and me. And I see Kirsty has made a comment that WhatsApp can be kept for departmental organization, and Vula or Synapse and apps which have more confidentiality for patient discussion. I think we are seriously encouraging, and we need to encourage more and actively use Vula for patient referral, because that is devised for that purpose. And yeah, I see Kirsty has also said that she takes verbal consent for burns patients and send it to the other doctors. I think everybody needs to do that. I see Gerard has a comment. Gerard, please go ahead.
Sorry, Prof. I just wanted to mention what I've noticed is easier on some of the other groups that I am. Instead of every time posting all of the rules and regulations and all of that, every time that we get a new member to the group, instead you can rather put all of those guidelines Kunita has mentioned all into the group description, and make sure that it's stated there that nothing should be posted. I see Kunita says it needs to have written consent, not just verbal, but make sure that everyone that posts takes responsibility for the post, but that these are the group guidelines and these are what we need to adhere to. Instead of every time having to post that, and as soon as a new member joins, they can just be asked, do they agree to the group guidelines? And that just makes it a bit more streamlined.
I think that's a very practical solution. Can I request one thing, Juanita? You have now studied this article, you have presented it to us. In the next month or so, by the end of July, or maybe beginning of August, can you bring out some guidelines for streamlining the use of WhatsApp for our department? And in the meantime, I would request all the members of the staff to email any specific suggestions about the use of WhatsApp for patient discussion to Juanita, and maybe in our department meeting, one person to person on a Monday or a Friday, say first or second week of August, we will just review those things, and then we will set up at least some rules and regulations for use of WhatsApp for patient communication. And I think that is a good thing. Before any new member joins, we show them the rules and regulations. I see Kirsty has made one more comment. Maybe a short separate consent form for burns patients only that we add to their files. So I think, Kirsty, if you don't mind, you have got 2 or 3 good practical suggestions. If you email them to Q, and anybody else who wants to email their suggestions about this to Juanita, and we will discuss them in the beginning of August, and we will then find it out, we will finalize them. Yeah, I think just send your suggestions to Juanita, and then she will summarize and we will finalize them in August. Anybody else has any comment, any specific question, comment? Anna Marie, Taryn, Nicole, anybody else has any comment? Sorry, I'm trying to unmute Anna. It's not easy to unmute somebody. Okay, managed to unmute Nicole. Still battling to unmute Anna.
Oh, hi, Prof. Yes, I'm not on mute anymore.
Okay. So I don't know, Nicole, you wanted to make any comment or any
There was one thing that I did want to mention.
Yes.
Just to start off with, I think conversations like this are so important. And even when we recognize that the second best, third best option, such as WhatsApp, even though it's not ideal, it's good that we still discuss gold standards and ideals, because in our context, generally, we're dealing with a low resource setting. So we try our best with whatever we have. And then also from what was mentioned earlier, I think we should always try to use Vula, but as you say, or as was mentioned with WhatsApp being ubiquitous, if we are then choosing to use the not ideal option, as has been discussed now, the kind of contingency plans around that and admin to try and protect ourselves as best as possible is essential. The one thing that I did consider, as was mentioned by your colleagues, is the fact that if we discussing patients versus patient care, and a lot of the time the reason we're having these discussions on a group is because we're one of the short resources. We're trying to be in 3 places at once. And so in a way we are doing the best that we can with the little that we have for the most amount of people. And in that way, I do think that there is some kind of utilitarian ethics to fall back on there if we ever were in that unfortunate position. But as someone in a rural referral hospital, the value of a WhatsApp or Vula discussion cannot be underestimated. So, yeah.
Okay, those are very, very nice, valid comments, Nicole. So thank you for that. Are there any comments, more comments? Otherwise, we can conclude the meeting. Anybody else would like to make any comment? Okay. If not, thank you everybody. It was really very good discussion, And once more, I just want to say the request once again. Please, whatever comments, suggestions, advice about ethical use of WhatsApp for our communication, because I think for the time being, we will not be able to get rid of WhatsApp for our patient communication. But with all these things like using short forms, avoiding photographs of the face of the child, and we want to send our comments and opinions to Vanita, and we will finalize it in the month of August. Okay. Shall I end the meeting? Thank you, everyone. We will see you next week. I will send the invitation for next week by Monday next week. Thank you all.